About supraventricular tachycardia in general and AV nodal reentrant tachycardia in this session. So, among the regular supraventricular tachycardias with regular rhythm, you have the sinus tachycardia, you have the sinus node reentry tachycardia, you have the atrial flutter, atrial tachycardia, AVNIT, junctional tachycardia, and AVRT. So there are 4 points to differentiate among the various regular SVTs: the onset and termination, the heart rate, the P wave morphology, and the RP relationship. RP relationship is from the interval from the R wave to the next P wave. So what is long RP? Long RP is when the RP interval is longer than the PR, then you call it as a long RP. When the RP is shorter than the PR, you call it as the short RP. So the differentiation of the various regular supraventricular tachycardias, the long RP tachycardias are the sinus tachycardia and the atrial tachycardia. The short RPs are the AVRT and AVNRT. And how does the heart rate help in the differentiation of the various tachycardias? The heart rate in hundreds is seen in sinus tachycardia, atrial tachycardia, and junctional tachycardia. Heart rate in 200s is AVRT, AVNRT, 300s and multiple is atrial flutter. So how does the P wave help in the differentiation of various supraventricular tachycardias? We get ectopic P's in atrial tachycardias and AVRTs. You get retrograde P's in AVNRTs and junctional tachycardia. So one important point we should remember while discussing about AVNIT is the atrioventricular node has a slow pathway and a fast pathway. Slow pathway has slow conduction velocity and short recovery period, whereas the fast pathway has a fast conduction velocity and a long recovery period. Slow pathway, slow conduction, short recovery period, 3S. So this is a typical AV nodal reentrant tachycardia where it is a slow fast AV nodal reentrant tachycardia. It makes up to 90% of the AV nodal reentrant tachycardias. You see narrow QRS complexes. P waves are hardly seen. If at all they are seen, they are merged in the QRS complexes in 2, 3 and AVF. So this is the typical AV nodal reentrant tachycardia. So the atypical, if there is a typical one, there is should be an atypical one. So it is makes up to 10% of the cases of AV nodal reentrant tachycardias. It's a fast, slow AV nodal reentrant tachycardia. So how do we differentiate from the typical variety? You see the P waves in between the QRS and the T waves. So it is a retrograde P wave. Follows the QRS complex and is before the T wave. So this is a fast slow AVRT. So how do we differentiate paroxysmal supraventricular tachycardia from sinus tachycardia? The P wave morphology is normal in sinus tachycardia. The P wave morphology is not typical in PSVT. The onset is sudden and the termination is sudden with PSVT, whereas the onset is gradual in sinus tachycardia. The heart rate, you see an heart rate in hundreds in sinus tachycardia. Maximum it can go to 220 minus age. PSVT heart rates in 200 is quite common. The heart rate is constant in the tachycardia phase in PSVT, whereas it is variable in sinus tachycardia. So next, what is a junctional tachycardia? So in a junctional tachycardia, the onset and termination is gradual. The heart rate is anywhere between 70 to 120 beats per minute, but still you call it a tachycardia because the junctional rhythm normally is around 40 to 50. Even 70 to 120 beats per minute is considered a tachycardia. The P waves are retrograde. The RP relationship is short and it's not terminated with vagal maneuvers. So I have just tried to give an overview and emphasize on some crucial points. This ECG session is being conducted by Dr. Akshay as an initiative from the Department of Medicine. So it will be dealt with in a methodical way or a systematic way this coming Sunday, and I too look forward to attend the session. The session will be conducted by Dr. Vijay Balaji, who is a resident in the Department of Medicine. Thank you. This is the depiction of the normal conduction in the heart. So there is an SA node, there is a AV node, there are slow pathways and the fast pathways. In the AV node, the fast pathway has a longer refractory period, whereas the slow pathway has a shorter refractory period. So the impulse which is generated in the SA node travels through the fast pathway and reaches the AV node, whereas the impulse that is generated in the SA node which goes through a slow pathway encounters a refractory AV node and a bundle of his. So, and it dies down. This is the normal mechanism. But what happens in AV nodal reentrant tachycardias? So, assuming a impulse from a ectopic focus, a premature atrial beat, again there is a slow pathway and the fast pathway. So this impulse which goes through the slow pathway goes through a different route and reaches the AV node. By the time it reaches the AV node, the refractory period of the fast pathway would have finished, so that the impulse again goes back and it takes a circle. So this is the recycle phenomenon or the re-entry phenomenon that triggers the paroxysmal AV nodal reentrant tachycardia. This is the typical way, typical AVNRT, where it's a slow fast pathway. That's the typical AVNRTs. You also have fast slow and slow reentrant tachycardias also.